Today we're going to be discussing something that NAMI helped to jumpstart, along with the Broad Institute and later the National Institute of Mental Health and later multiple pharmaceutical companies, nonprofits, and the Foundation for NIH. As you know, many people in the NAMI community want to know, when can we have better medicines for schizophrenia? And this is a multi-year $100 million public-private endeavor to try to sort that question. Our speakers are remarkable. The title is Advancing Schizophrenia Research, Integrating Lived Experience and Scientific Progress in the AMP Schizophrenia Initiative. AMP is the Accelerated Medicines Partnership. SCZ is schizophrenia. Next slide, please. Just so you know, we have a helpline. The helpline is fantastic. It is not a suicide prevention lifeline, but we have 350 volunteers a year if you want to talk to somebody or troubleshoot where to find help or support. We love our volunteers on the helpline, and we encourage you to consider becoming one. You'll get some training, you'll be part of a fantastic community, and you'll be making a difference for the NAMI mission. Next slide, please. I read your 296 questions that came in advance. I want to thank you for your curiosity. And I want to let you know that many of these topics have been discussed by national experts. So we just had a webinar on clozapine with probably one of the leading international experts on clozapine and the change in REMS. Many of you asked about anosognosia, lack of awareness of insight. We've had Javier Amador on this call. And for the NAMI convention, June 11, 12, 13, all virtual, Dr. Amador will be reprising his talk called I'm Not Sick, I Don't Need Help. Some of you asked about the keto diet. Our colleague Jesse Walthall identified researchers at Stanford who will be presenting on the keto diet and psychosis. So while we won't get to all of your questions, I want to encourage you to look at the library that we have created of expertise. Many of your questions can be attended to. Next slide, please. All right, so Carlos Larari, Michael Sand, the fantastic team. Carlos is the co-chair of the AMP Schizophrenia Project and brings his lived experience to the table. He also is a graduate of my favorite institution, the University of Michigan, one of my favorite institutions, Harvard University, where he got a master's in public administration. And he's also done clinical work. Michael Sand is a longtime friend of the family at NAMI who has worked in drug discovery as a consultant at many levels. And so the two of them provide both the lived experience aspect of trying to solve a tremendously challenging riddle and how a doctor, pharmaceutical expert, thinks about drug discovery. We're incredibly fortunate to have these two national leaders with us today. They're going to give a talk, 45 or 50 minutes, ask questions as we go, and we're going to get to them at the end. So next slide, please. Carlos, please take it away, and thank you for everything.
Thank you, Ken. Hopefully you all can hear me loud and clear. As Ken mentioned, my background is multidisciplinary, clinical as a nurse practitioner, legal as a attorney from Michigan, and in policy as a public administration student at the Harvard Kennedy School. But at the end of the day, the heart of why I do what I do and study all these different ways of understanding and solving problems is my lived experience. I'm someone who was diagnosed with schizophrenia shortly after college, and I came to NAMI when my mom dragged me to a support group, albeit the wrong one, a family support group, where I, quietly in the background observed everyone's conversations and, had my first light bulb NAMI moment and explaining my gratitude for everyone sharing their lived experience and understanding what the family member's perspective was like. And from there, I kicked off my career with NAMI in the sense that I became a peer support group facilitator, joined the NAMI Miami board, joined the NAMI National Board, and now co-chair this initiative to bring better treatments for people at high risk for psychosis. So it's been quite a journey, and lived experience is still at the heart of my my passion and advocacy. So next slide. So today, we're going to present in 3 stages. The first is going to discuss what I think is the justification for why lived experience should be in research. You could advance the text there, Hagen. Thank you. Exploring the scientific and ethical basis. As advocates, we kind of have to justify, our existence in some way. Not to be too philosophical about it, but certainly as a person with a stigmatized condition, sometimes I feel I have to. Uh, 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 the second part, we're going to look at schizophrenia specifically as a case study of this incorporation of lived experience in mental health research and why I think it's provided value to others, not to mention NAMI's tremendous role in getting it kickstarted and getting it off the ground, including advocates such as yourselves. And for the third part, we'll look at kind of this emerging field of incorporating lived experience into research. And again, looking at the case study of schizophrenia, some of what I think are best practices if you or your work involves bringing people into lived experience into the fold. So next slide. So I think there is a scientific basis for incorporating patients. It's historically known as patient-oriented research, and including in the context of psychosis, the evidence suggests it increases the relevance, feasibility, adoption, and implementation and sustainability of mental health research. For example, one of the innovative models is using, and what we'll look at is digital mental health tools like phones to collect data. And knowing how this works on the ground can be helpful to scientists, researchers, because sometimes, people share their phones and maybe the data they're collecting isn't truly reflective of the person it's supposed to collect data on. And that's kind of one of those real world things that you understand when you're on the ground as a patient or family member. In the context of schizophrenia, it also reinforces the need for addressing the unmet needs, cognition and the symptoms of negative symptoms. Your loved one may not be hearing voices or hallucinating anymore, but they could still struggle getting outside the house and kind of want to stay indoors and are not achieving a life with relationships or meaningful work. So there's an evidence base that goes back well over 40 years. There's also an imperative for, I think, incorporating lived experience from a diversity, equity, and inclusion lens. That includes changing the culture of the research environment to perhaps promote researchers with disabilities or view the patients as co-equals in this enterprise. And as I mentioned in the example earlier of using digital tools like smartphones to collect data, the direction the field is going in, there's also ethical challenges with that, including data privacy, autonomy. That is important to have patients and caregivers at the table to share their concerns and how they want the research to proceed. Next slide, please. Again, from an ethical perspective, this aligns with pillars of medical ethics, such as doing good, don't avoiding harm, promoting autonomy and justice. There's this idea of epistemic injustice, where people from marginalized groups are denied opportunities to create knowledge and find meaning in their experience. For me, I get a great sense of purpose by taking my suffering and adversity and turning it into and struggle into a way I can help others and contribute to understanding this illness and hopefully a better future for people who have had this journey. And not only is it empowering and can lead to better knowledge creation, it's imperative from the disability rights perspective as well. Nothing about us and without us. There is a history, unfortunately, including in psychiatric research, of people with serious mental health conditions or other disabilities having research done on them and not with them. And that's led to unfortunate outcomes in the past. So those slides kind of capture a little bit of the scientific and ethical justification for lived experience, because this historically has not been the norm and it's still kind of an emerging practice, if you will. Next slide, please. So now let's take a look at the schizophrenia program in specific. So one more slide, please. So, Michael's going to do a great overview of schizophrenia, including its goals, and so I'm going to look, and including the scientific aspects of it. So I'm going to look more at kind of the historical development of it, and but at a high level, it is a public-private partnership that aims to bring together all the stakeholders, advocacy, federal government, industry, to solve this problem of developing better medications for people at risk for psychosis and schizophrenia in particular. we can trace its origins back to advocacy. One Mind, led by Brandon Staglin, a person with lived experience, was instrumental in funding the North American prodromal longitudinal studies. The purpose of that study was to develop tools to predict the onset of psychosis. They funded studies that ran for nearly 20 years and involved a variety of biomarkers, including EEG measures, structural MRI, and genetic indices. Ultimately, this initiative formed the scientific and research basis for the AMP schizophrenia biomarker studies, which again is ultimately trying to find biological markers that will lead to better treatments in this population at risk for developing psychosis and schizophrenia. Next slide, please. So where does NAMI come into this fold? Well, NAMI, including people like you and advocates, knew what was going on in the ground, knew that, these medicines help our loved ones, not be in crisis, but they're not doing that great of a job of helping them get out into the world and get motivated to find jobs or pay attention so they can do the work they need to do. So there was an unmet need there, and NAMI hosted a Advancing Discovery Summit back in 2014 that brought together all these stakeholders and helped the initiative get off the ground. It took a concerted effort, bottom line, it took a concerted effort of multiple attempts, starting as far back as 2014 to lead to the initial and eventual launch of AMP Schizophrenia in 2020. People like Ken and Terry, as well as other NAMI advocates, as well as industry leaders like Steve Heidman and Tom Hinsel, former NIMH directors, also recognized this tremendous unmet need and felt something needed to be done. But it took concerted advocacy and effort to build up the will to make it happen. It's an ongoing project, and it's supported by active participation by NAMI participants or members like me, as well as donors such as the Shear Family Foundation. And hopefully this is the start of what is more breakthroughs in mental health research as NAMI brings together people with one kind of vision in mind, various stakeholders. All right, next slide, please. So from the start, NAMI helped bring this off the ground, and lived experience has played a crucial role in the leadership of the initiative. It's co-led by three of us, kind of one representing each pillar of the industry sectors: private, government, and nonprofit. The hope is that, including lived experience, the voice of the families and people are challenging is at the table. At the highest levels, from developing the research plan to ensuring, patient burden isn't too onerous, that we're not, doing too many assessments or tests. Lived experience is considered, and everyone in the project has been on the same page with ensuring that this is a transparent process where all partners are at the table. I'll say a funny aside. When I was considering this opportunity, I really had actually no interest in it. I thought like there was an MD, PhD, running for this job, if you will. I only had a few letters at the end of my name at that point, so I was like, I don't probably got a shot at this, but someone threw my hat in the ring unexpectedly, and the NAMI, the steering committee for this project voted me in, and it's been the most rewarding work I've done so far. So it's kind of funny how a democracies can, processes can be a little surprising, as well as speaking to the appetite there is from all the stakeholders to keep this centered and grounded in the patient voice and perspective. So next slide, please. Again, its involvement is at the highest levels, including the research design, study protocols, reviewing that, and ongoing conduct of the study. Again, we discussed the importance of considering patient burden, how these assessments are going to be, how onerous they might be on patients, and we also discussed, kind of the ethical and appropriate use of sensitive data and the data sharing process of these tools being used with participants. So I am going to now go from kind of the high level to a little bit more granular because, as much as there is, leadership involved, there is some getting in the weeds, which can be fun as well. So next slide. So an example of kind of the more granular level is this co-designing of digital tools with people with lived experience. If I may read this quote from John Torres, who's an expert in kind of digital psychiatry. One of the tools we use is an app, if you will, called MindLab. So the digital assessment platform used in the AMP schizophrenia studies, in particular MindLab, has been built over the last 5 years with direct co-design and over 200 updates. So its design reflects the input of many stakeholders with lived experience. This involvement, coupled with actively sharing research data from the app back to the users, has helped to build trust and contribute to the app's robust uptake by more than 80% of study participants. This surprisingly strong engagement is now yielding useful data to support the AMP's aim to lay the groundwork for developing original medicines to treat people in the earliest stages. So a lot of scientists prior to hypothesis was that people with psychosis are going to be or at risk for, are going to be suspicious, maybe paranoid about sharing. But it turns out, I think part of the co-engagement of people with lived experience and the iterative process of having them at the table surprised many, and the app is working in a way that's collecting great data and has high uptake. Next slide, please. Another interesting anecdote that I enjoy to share is when we did a engagement with the scientists, and I shared my lived experience and how that shaped research inquiry. So I wrote this paper talking about kind of the unusual movements with the eyes associated with psychosis. My mom would, the painting there is a Counter-Reformation painting of a saint or martyr, and I kind of would look like that. I kind of stare off up into the ether or the heavens, and in a way that people obviously noticed something was off or strange. And so I'll read this as well. I would often focus my gaze on unusual spots or avoid eye contact with others due to the social anxiety or cognitive impairments associated with the disease. My eyes would fixate on the ceiling as if I were a figure in a Renaissance painting, a martyr or saint looking upward, awaiting the arrival of kingdom come. This frequent, intense upward stare prompted those around me to ask, "What's up there, Carlos? What's going on?" This behavior distanced me from normal social exchanges, leaving my friends and family feeling awkward and confused by my attachment. When I shared that experience with the scientist, he thought, hey, maybe there's something there. Maybe, there's something with not only eye contact, but perhaps the plane in which the face is facing. Normally we kind of face at each other like this, but if someone is facing this way at all times, up towards the roof because they are afraid of making eye contact, or they're facing down because they're depressed and they don't want to make eye contact. If we measure that, could that be an objective indicator of behavior outside the norms that could Another interesting one I shared with a colleague at the Schizophrenia International Research Society of late was, I know we're looking at negative symptoms, or things that have a negative valence early on, such as, terror, fear. But, there was actually aspects of my psychosis that felt kind of positive at first before it became scary and terrifying. I remember in my mind, at some points, I was at the pool at college and I felt like I must be in the Garden of Eden. This is utopia. I wasn't grounded in reality either. But it wasn't a totally negative experience. And that's consistent with some of experiences of people hearing voices in psychosis. It ultimately became very dark and negative, but maybe there's a signal that's even earlier there. And they found that was interesting. But so all I have to say is the back and forth conversation between scientists and people with lived experience can also help the empirical process, hopefully discover new things. Next slide. So we've been also very active with website outreach, kind of the branding or the marketing, if you will, of our project. This website was developed again with people with lived experience like myself input. It's a public facing website both for researchers and people and families. And we're finding that a significant amount of traffic to the website is coming from NAMI, maybe in the top second or third of traffic engagement is coming from people with lived experience and their families connecting to this program. Next slide. Again, this is another example of the effort and the importance of I think communicating lived experience along with scientific process. I think that makes the data that more compelling when you have a narrative and you have a real world impact behind the evidence that's coming out. So we've published in NAMI Advocate, as well as podcasts, as well as peer-reviewed publications, and we're really trying to a kind of no stone unturned approach when it comes to sharing our work, its importance, and the urgency for more of it. So that, again, this is a bit of a whirlwind. This is, high level, but, I also want to save time for the science, which is, really fascinating as well. I do want to touch upon a few things about, how lived experience can help you in your work. This is mostly in the context of research, but this could also be in service delivery if you employ peers, or other ways where, people's lived experience can add value. So this is again, we kind of discussed the ethical and scientific justification for lived experience, improving research quality, outcomes that matter to the patients. For the persons participating in it, there's actual like a sense of hope and empowerment and agency that I'm not just a victim of my experience, but I'm helping to overcome it and help others. And I think this helps kind of with this issue we're having now of trust in scientific institutions and decrease stigma as well when stakeholders are communicating together with a common goal or good in mind. Next slide. So at a high level, we'll go through this in the next couple of minutes pretty quickly. We'll talk about culture next and how we can encourage people with lived experience to participate. We'll talk about systems to do so systematically, so it's not just checking boxes or kind of an afterthought, and what resources should be and are available. So next slide. So culture plays a big role in all this. NAMI gets it, the people in industry get it, but maybe there's other spaces where they don't totally get it. Maybe it's in the policy world, or maybe it's in the business culture. But a top-down buy-in from leaders, is I think the way you change culture. So not only does it address issues of diversity, equity, inclusion, but it also I think leads to better delivery of the services or the products. One thing I want to just highlight here is, for people like myself, one cultural aspect to consider if you do work with peers is, is their lived experience is just one facet of the many identities or hats they wear. I'm also a clinician and lawyer, and I bring multiple skill sets, even if, lived experience is kind of the true north or the moral compass that guides it all. But we don't want to see people in a tokenistic fashion just for the illness. We want to see the whole person. So I'll go to systems now. Next slide. In all fairness, it's, not to be Pollyannish, but there's room for improvement here also. I'm just an N of maybe one or two in this leadership between Brandon and me. We're certainly not getting involvement from the global mental health core, or particularly from young adults in the throes of the clinical high risk. It's still, in my case, a passion project, a volunteer, a pro bono, if you will. But we could work towards, creating systems where people are incentivized to participate with lived experience and compensated accordingly for their expertise with experience. One model is, we're lagging behind here in the States, but other places like UK have specialized tracks for lived experience researchers in academia, where they can bring both their kind of empirical and professional skills as well as their lived experience to their research and work. That's one model, but we're going in the right direction, and there's still, room for improving how to fairly and appropriately work with people with lived experience. Next slide, please. And lastly, resources. Again, this isn't a one-off thing. This isn't just a checking a box. This is like an iterative process, and supporting people with lived experience is not just cultural, by creating a safe space where they can take time off if they're maybe triggered, or if people are asking too much of them. We all kind of feel that in NAMI sometimes, where we're putting our heart and soul into it, and we need to take a step back. But it's also resource and system oriented, where we want to make this the standard operating protocol, if you will. And and again, one way to do that is through treating people with lived experience and families as the appropriate experts they are. All right, and I think we're getting close to my end of it. There's one more slide or two. I just want to thank you all, everyone in the audience, particularly advocates, family members with lived experience. Your work is what's helping make progress and giving me hope and others hope. I'm hoping to share, the work we're doing today to kind of inspire you and reinforce you, to understand your work and your impact does make does make a difference. And despite the uncertainty in the world, despite the challenges, I'm hopeful that this will become the norm. This will become standard, where patients and family members, a lot of it's patients now, but there's still room for family members to be part of the conversation of mental health research and creating better medicines and more inclusivity in the field. So last slide is, a very smart man, clearly smarter than me, said the only source of knowledge is experience. And, if it was good enough for Albert Einstein, it's probably good enough for all of us. So, Thank you all. And I'll save questions for later, and I'll turn to my colleague, Michael.
Well, thank you, Carlos. As always, your voice is so important and welcome. And I'd like to thank Ken and NAMI for allowing me the privilege of sharing with you all some of the work we've been doing over the last years as part of the Accelerating Medicine Partnership, the AMP Schizophrenia Project. I was privileged enough to first get involved in this when I was conducting, in my naive view at the time, some work in cognitive impairment in people living with schizophrenia, and happened to be at a conference where the Naples investigator that Carlos alluded to earlier were presenting some of their data. And I had this wild idea that perhaps it might be possible to use a pharmaceutical compound to delay or even perhaps prevent the onset of schizophrenia. Because we know schizophrenia doesn't happen overnight. It's not a switch that suddenly gets turned on or off. We know that there's a period of time when people experience what we now call the clinical high risk, or CHR, for psychosis. And this period of time happens to people in their early and late adolescence and into their early 20s. And they go through a period of time where they are not floridly psychotic, but they are having impairments that are demonstrative and causing them distress. So the Accelerating Medicines Project is a very large international collaboration that's focused on developing tools to create algorithms and biological markers that can distinguish the trajectories of these individuals with the goal of ultimately developing new medicines. And the program has two parts. The first part is an observational study in which we have recruited people at clinical high risk and controls, and I'll talk much greater detail about that. And the second part of the initiative is a proof of principle trial when we evaluate these biomarkers in a clinical trial with a compound to see if there's any detectable signal that can be determined. Because this is one of the things that has stymied research in this area. Next slide, please. So when we talk about the AMP Schizophrenia Project, I want you to be aware of the enormous size and complexity of this. This is a research project that involves research sites on 5 continents. There are 2 networks, the ProNet network in North America, South America, and some in Europe, led by Scott Woods at Yale, Kerry Bearden at UCLA, and John Kane in New York. There is the Prescient group, which is led by Barnaby Nelson and Pat McGorry in Australia, and includes Asian sites as well as Australian and European sites. And then there's the DPAC, the Data Platform and Data Processing Analysis and Coordination Center. And this is led by Marty Shenton at Harvard and Renee Kahn at Mount Sinai. The amount of data that's being generated, you'll see in a moment, is truly staggering. Next slide. So I think we're going backwards. Let's go forward. Oh no, this is fine. My bad. The primary aim, again, yeah, that's okay. You can leave this up for a second. Is to get baseline data, and again, we're looking at 3 endpoints in this observational study. The endpoints are conversion to psychosis, remission of the symptoms totally, and then this group in the middle who neither converts to psychosis over time, but also is continuing to suffer impairments. And out of that, we hope to be able to phenotype people with biomarkers to see what actually these differences are, and if we can predict which group they're going to be in and what leads to people being in those different groups. Next slide. This next slide shows you just a schematic of the visit schedule at the months, over 24 months, and the kinds of data that are being captured. Extensive interviews and clinical questionnaires, cognitive testing, MRIs of the brain, EEGs of the brain. There are blood and saliva samples. There is daily actigraphy data from a watch that people are given. There's digital data, what we call EMA, or ecological momentary assessment, in which people are asked to record how they're feeling and doing on a daily basis. Audio diaries. We're looking at speech sampling, facial recording. All of this is coming into this enormous data set. Next slide. So when it comes in, it is not just one or two variables. I wanted to, you don't have to pay attention to what these are, as much as look at just in this group of variables, there are almost 600 different things we're looking at. So its scope is larger than anything that has ever been done. And we hope that as a result of that, we're going to, and already are, generating insights into this incredibly important stage of psychotic illness with the goal of, again, ultimately developing therapies to address it. Next slide. Where are we at? These 42 sites across the world ended recruitment in January 2025. We have exceeded our targets and have recruited over 2,700 individuals, 2,000 of people who are young people at clinical high risk, and over 600 clinical controls from the same communities. Now, obviously, this is an observational study over time, so the amount of data we have at any given time point varies. So, for example, we now have data from 2,000 people for baseline and month 2. There are about 900 that have gotten to 12 months. And over that period of time, we have 66 individuals who sadly have converted to psychosis. We project that all of the clinical high risk and 90% or more of clinical controls will complete their month 2 time point by the end of May. And by the end of April next year, we will have 1-year data in all these folks. Next slide. So what are we learning so far? Well, some of you may know that in the DSM, our sort of psychiatric insurance and diagnostic manual for mental illness, the idea of clinical high risk is listed under the title attenuated psychosis syndrome, and it is listed as an area needing further study. It could be added into the main DSM as something physicians should be looking for and treating. Well, one of the things I am a passionate advocate right now is that based on the AMP data, we can now move this from needing further study to a clinical condition needing to be addressed now. Let me share with you some data that supports that. These are data that I recently presented in the Schizophrenia International Research Society. These are from Jean Addington and her colleagues at the University of Calgary, leading the group working on clinical scales. And what they have found, looking at the baseline data, this is at baseline coming into the study, that compared to the clinical controls, whether we look at the negative symptom inventory with things like anhedonia, asociality, avolition, lack of motivation, blunted affect, psychiatric rating scales on negative and positive symptoms, the Calgary Depression Scale, which is designed to assess depressive symptoms in people with schizophrenia, the Columbia Suicide Severity Rating Scale, which is the gold standard instrument used to assess suicidality, what we have found is that people in the STAR cohort score statistically significantly worse on every single one of those scales. The same is true for the patient impression of their severity, their anxiety, their perceived discrimination and stigma, their stress, and their sleep quality. On every single one of these measures, people in the clinical high-risk cohort perform more poorly. I think it's time we take this out of the needs to be studied more and move it into the needs to be addressed more. Next slide. These are some results of the cognitive battery, and the cognitive battery used is something called the University of Pennsylvania Computerized Test Battery, the PEN-CNB, and it's a series of cognitive tasks that are administered to individuals knowing that they tap into different domains of cognition, like working memory, verbal memory, executive function. And without getting into the nuts and bolts of this task, what I want you to do is look at the graph on the upper right. You see there the Z-scores. These are deficits below baseline that one sees the clinical high risk compared to those people who are healthy controls. And you don't have to be a scientist to look at that and know that the people in the clinical high risk group have profoundly more impairment when it comes to their cognition. This is long before they've been done with any psychotic illness. They're already struggling. Next slide, please. One of the things that has all of us very excited, among other things in this trial, is that we are now including digital measures in a larger naturalistic context than has ever been done before. And this is hugely important, as Carlos has acknowledged, looking at actual lives and not just what happens under the microscope of a clinic visit and assessment. And so again, we're going to have 12 months of digital assessments and monthly digital check-ins. And again, we're already getting phenomenally interesting results, and I'll share some of those with you. Next slide. These are data that from John Toros and Justin Baker at Harvard, who lead the group looking at the digital biomarkers. And what you see here in some of the data is how engaged people actually are with the digital data and the watch actigraphy data. But interestingly, irrespective of their levels of engagement, it's fascinating to see that over the first 12 months, whatever someone is doing at month 3, they continue to do for the next 12 months. Any idea about what this would actually look like? Now we start seeing for the first time, what these digital phenotypes may look like. If you go to the next slide, we are also able to see, as part of the data that are generated digitally, speech analysis. And this is just one slide from the speech analysis group led by Phil Wolf and Cheryl Corcoran and others that shows us that the parts of machine learning to analyze these, at 2 months, they are able to discern the difference between clinical high risk and people who are healthy controls. Now, I'm sure I don't have to talk to this group about the incredible burden that stigma places on people living with mental illness. If there were a way for people to essentially be monitored more closely in their daily lives without having to go to a hospital, without having to go to a clinic and sit in public, but simply speak into their cell phones, what might that do to provide more precise care, but also less stigmatized care? So again, exciting for all of us to see that at as early as 2 months, we can discern the clinically high risk from the controls on the basis of their speech. Next slide. This is just to give you a little bit of a flavor for some of the other kinds of things that are being looked at. Dr. Pratt and colleagues are looking at certain aspects of cognition, processing speed, and how that correlates with functioning at baseline and at month 2. And as you can just see from the graph on the left there, they don't look the same. People at high risk have deficits that their function. Dr. Wastler and her colleagues have looked at the incredibly higher risks of suicidal ideation and suicide attempts compared to people in the healthy controls, and have correlated that, finding that they have greater sleep disturbance. So there's a correlation between lifetime, past month, and attempted suicide with greater sleep disturbance. What do we do with that? How do we intervene in it? We don't know yet. But these are the kinds of insights that are being generated that are going to provide a generation of researchers with targets to try and improve these folks' lives. Greg Strauss down in Atlanta has looked at negative symptoms and found again that these scales that we have developed for this work, they're reliable, and they demonstrate clear differences. So we know we can use these to measure folks. And then other folks are looking at more complex analysis to try and look at how all of these things fit together, because it isn't just one thing. All of these things play a role together. And that's something that's been missing in the past, the ability to do these incredibly deep analyses that put them all in the mix at the same time. Next slide. Next slide, please. This is just a random sample of 12 papers of the over 50 papers that are just currently in development from the baseline data. And you can see that they range from things from MRI to EEG to cognition, you name it, we're looking at it, and different scientists are looking at correlations and analyses to try and pull this together, all with the goal of finding biomarkers that, again, can give us confidence that they will show different trajectories of conversion, remission, and those people who do neither one. Because then we have some ways of doing drug development that we have not had in the past. Next slide. Next slide, please. There we go. This is almost one of my last data slide, and this is just to demonstrate some of the new exciting stuff that we as scientists are looking at. This is an analysis called principal component analysis statistician. But the intent of PCA analysis is essentially to look at all of these things being tossed into the mix to see what individual contribution individual things make to the overall picture. And one of the exciting things I'll show you on this slide that has all of us very, very interested is the third bar down, okay, which is the green one. That is digital data, okay, from ecological momentary assessment. So one of the strongest effect sizes for looking at and characterizing the difference between high risk and clinical controls is a digital device. And that has potentially enormous promise for not only doing trials, but for designing interventions. Next slide. I think it would be important to talk then just real briefly about what comes next. And that is a proof of principle trial in which we take all of these learnings from the biomarkers and outcome measures and put them into a clinical study with several compounds to see whether we now see, using what we think are much better endpoints and much better measures, whether we can see movement on them in a proof of principle study. And if we can, then the whole world of drug development becomes much more facilitated than it ever has been in this incredibly important area. Next slide. Those studies are being done, are being drafted as we chat today. The protocols are being written and being finalized, and we hope to actually start one of them by midsummer. Again, this has not been done in this way in the past ever. Next slide. So I would be remiss if I didn't acknowledge the steering committee of incredibly talented, hardworking people at both government, industry, FDA, and people with lived experience who have been working on this together for years, as well as the incredibly hardworking staff at the NIMH and the Foundation for NIH, without whom we couldn't do this. I hope you have a flavor for the incredible size of this project and the benefit it may bring. It's unprecedented in our history of studying this. So again, I need to give profound thanks to the hundreds of dedicated scientists, to the staff of the NIMH, and of course to the over 200 or 2,500 young people and their families who've contributed their lives, their time, and their struggles to give us these data in the hopes of helping others. And I'll leave you with two thoughts. One is Margaret Mead's quote that you see there. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing it ever has. And the other thing I will say is, for those of us who've been on this journey for a while, there's an old Greek saying that a civilization is thriving when old men plant trees knowing they will never live in the shade. We may not be around in my career to see this pan out with effective drugs where we actually delay or prevent psychosis, but we are way farther down that path now as a result of the incredible hard work of these people in AMP Schizophrenia. So thank you very much for the opportunity to chat with you. And again, NAMI, who has been at the table and pushing and driving this one. It's been a privilege to be able to share this with you today. Thank you.
Thank you, Carlos, and thank you, Michael, for all your hard work. Couple questions about you, Carlos, just you personally. What helped you? What made a difference for you? When were you first diagnosed? How did you become so ridiculously accomplished? I'm going to say there's a half a dozen questions about you, Carlos. So let's just start with that.
Well, and I was taking a look at the questions, and I want to frame it again in the context of this work. We looked at really the biomedical and the scientific side, but recovery is much more than that. The medicine, I think, is the necessary piece of the puzzle, but it's not the sufficient piece. It's not enough. Another way of thinking about it is kind of that first domino that puts all the other dominoes in falling in line. Or another way to think about it is like, look, if I had a heart attack, sure, we could talk about the keto diet. Sure, we could talk about peer support, but please take me to hospital first where I get some medicine. It's the same is true for a brain attack with psychosis. So, once you get the medicines piece, and this is the focus of AMP Schizophrenia, is better medicines for people earlier on so they can have better outcomes, then you can do the work of recovery. A big piece of my recovery was early intervention. Getting help earlier, and that's the focus of this effort as well. And another part, I'll just touch on a third one, is advocacy and finding meaning and purpose in your suffering, your struggle and adversity. And for me, it's been being able to give back through NAMI and give back to this initiative. And I like Michael said, I hope one day I'm sitting retired on a front porch telling my kids, back in my day, we had to, put on 40 pounds when we needed to take antipsychotic medicines, and people had to go to the hospital, and they'll be like, yeah, granddad, whatever. When we have better treatments that can avoid diagnostic labels that are stigmatizing, can get people with less side effects, can get people earlier on so their life is less disruptive and they can go on with their goals. But progress is being made, and it's a privilege to work on this project. And I like how Michael's slide ended with a quote on the importance of advocacy, and my slide ended on a quote on the importance of science. It's kind of it's these two worlds can come together for the better good of all of us. Yeah.
Thank you, Carlos. Some people asked about early intervention. This is not an early intervention study. This is a massive international study to look at the clinical high risk state with the hopes that there's biological markers that will identify conversion to psychosis, and that will inform treatment. If you need early intervention for psychosis, this is one of the best ideas in the history of American mental health. One of my colleagues will put the EpiNet website into the chat. EpiNet is the early psychosis creative model, intervention model, developed by the NIMH and SAMHSA. NAMI supported this. NAMI got it into the state block grants. This is the idea that you don't treat stage 1 psychosis the same as you treat stage 4. And in this way, it's a staged public health intervention. There's about 350 programs across America. This is a fantastic program. This is not AMP schizophrenia, but because we're talking about the early course, I want to make it clear, and I want one of my colleagues to just put that in there because a couple people asked about it. Michael, let's talk about the science side. Several questions about clinical high risk. Why is this project focused on clinical high risk? What have you learned from the population of clinical high risk so far? So let's drill down. It's a massive multinational initiative. Tell us about that decision as opposed to simply trying to do drug discovery.
Ken, there are a couple of pieces to this. One is, again, we have known for a long time that, like I said, people don't just simply walk off the cliff into schizophrenia. But when you talk to many community psychiatrists, and I've had this experience, and you ask them about this, you will get answers like, well, yeah, I know there's something that happens before they become psychotic, but I don't see those people. I don't see them in my practice. And that puzzled me because I thought, well, are they just not being seen? Are they not being bothered enough by this? One of the things we have learned is, yes, they are absolutely being bothered by it. They're being distressed by it. But they're not being recognized for what it is. And I used to show a slide when I would give talks on this where there's an illustration of a bucking horse with a cowboy closing the barn door behind it. And I used to say, the intent is to try and get to this before the horse is out of the barn. We want to be able to identify who is at risk. Who is a young person that's just having a tough time and having some, depressive symptoms or anxiety symptoms because they're at school for the first year away from their parents, versus who is the person who is really at risk for developing lifelong serious mental illness. That's the intent of this, and that's what has led to, the recognition that we need to do more and learn more here.
Big challenge because a lot of teenagers become isolated, may even have paranoid thoughts if they're socially isolated or struggling. So it's a big pool to go after, but I like the analogy of the barn door.
And Ken, to that point, like I was saying, imagine if we can say with confidence in a few years, have your son or daughter read this paragraph into their cell phone on this site, and we can give you a good picture of whether or not they are at some serious risk and need to be seen immediately, as opposed to my kid's just struggling a bit in school. Because right now we don't have that. And if we do take them out of school, they deal with the stigma of, I have to go see the psychiatrist and,
right,
all that goes with that.
A good question about, does this capture people who will later on develop schizoaffective disorder? So schizoaffective disorder is kind of the space between schizophrenia and bipolar disorder.
So my answer to that has to be, we simply don't know. We are going to definitely learn more, but whether or not we will have an explicit answer to that question, we simply don't know right now. You know, one of the things that we all who work in this field and many people who've gone on this journey with family members have come to understand is, while we are learning more about the brain than at any time in our history, there's still such enormous amounts of things we simply don't know yet about the brain that we can't answer all of these questions. But it's initiatives like this that are going to help us move that ball down the goal line. I mean,
Massive multi-site international programs with a specific aim in mind.
yeah.
For the person asking about schizoaffective disorder, there were several. I would commend to you Dr. Deanna Kelly's talk on clozapine last week. Last month. Clozapine is the only FDA treatment approved for treatment-resistant schizophrenia, and it has been shown to be helpful for schizoaffective disorder, and in an off-label, non-FDA approved way, can be a good anti-manic agent. That's an aside. You know, I think I have to be clear, that's not FDA, but that's what clinicians think. And if you think there's mood dysregulation in both conditions, it would make sense. Let's talk about funding. There's a lot of funding cuts these days. How secure is the funding for this project?
Well, I have to be careful and not be too flippant here, because I'm not with the FNIMH or NIH. I would ask, how stable do we see anything coming out of Washington on decision-making around finances right now? We seem to see, you know, a lot of chaos, quite frankly. We see people being let go and rehired, and we see things seeming to be shut down and then maybe not. There's certainly a lot of anxiety within, I think, all of the federal agencies right now that I engage with, whether it be the FDA or NIMH. Currently, it looks like this is secure. Can we predict that's where it's going to be in 6 months? No, I don't think we can. That's just my opinion, though. I'm not speaking as an insider into that.
I'll add one thing, if I may. As a person with lived experience, I get a lot of hope in the science. It's the candle of light in the dark. It's what keeps me hopefully planting those trees for the next generation. But the science also is a necessary but insufficient piece. You also need, advocacy and political will to get buy-in and get investment. And that's where, in particular, I saw some people asking, like, what can we do today? And that's where NAMI, comes in, is making sure the voices of lived experience are heard. They're at the table with decision makers, and people understand the real world urgency and impact of this, so that the science can be, funded and move forward.
Question, is this clinical trial closed? How do I participate in research? NAMI has a very nice page that our colleague Jesse Walthall runs. But let's talk about this access to this study.
So the AMP observational study recruitment is closed. However, recruitment into the clinical trial has not begun yet. And so I would encourage anyone that is interested in going to the AMP Schizophrenia website. We can certainly get that posted for everyone, Ken. There's an enormous amount of information there. And another thing that I didn't tell you about this project, which is stunning, I think, when you hear this, is any researcher in the world can have access to these data. These data are not being held by this consortium. They are going to be freely available in their entirety in staged releases, so that any researcher wanting to do any analysis of this can do so. And we encourage that to happen. But again, in terms of moving forward in the clinical protocols, there will be opportunity to enroll in those studies. And I would encourage anyone interested in following along the website when that becomes available. you'll be able to find out where the sites are and if you can participate.
We'll do our best to let people know. One of the important things about that model that you just described is that's counter to virtually every other model. And I just want to take one moment on this. Drug discovery costs a lot of money, in the billions. People tend to hold that data close. Academicians want to get published, promoted, become full professors. So there's a natural tendency to hold on. This project, it's all open science. So it's this massive international study of clinical high risk, and it's all open science. And I just want to emphasize how unusual that is and how fantastic that is.
It really is. And Carlos, I want to just come back to what you said. I couldn't agree with you more that now is the time for advocacy. If ever there was one, now is a time for people with lived experience who are struggling and their families are struggling to do all you can to bring this to the attention of legislators, etc. Because if anything will support this, it's probably going to be advocacy.
And advocacy is really what got us here. It was a lot of people who really wanted to, solve this riddle of the underlying biology. What is the underlying biology that drives different presentations with schizophrenia? There's probably many schizophrenias, and the identification of biological underpinnings is the key. Carlos, go ahead, Michael.
I just wanted to share with this group because I think this may resonate. When I was talking about how it seems unrecognized, when I was doing work a number of years ago in this, trying to figure this out, short of doing an enormous long study, which would be pretty impossible to do, quite frankly. How do you get at what really is going on in communities? And we partnered with an insurance company in the US, Anthem, who covers 75 million lives. And working with their epidemiology group, we identified a cohort of 7,000 some patients who had a first diagnosis of schizophrenia in their symptom. We matched them to 27,000 people who were age, sex, and region matched and looked at the previous 5 years of their healthcare utilization. And starting 5 years before they were diagnosed, the cohort who developed schizophrenia used twice as much healthcare, and that went up to 5 times the healthcare the year before they were diagnosed. So these people are suffering, they're seeking help, they're being prescribed lithium, they're being prescribed SSRIs, they're being prescribed Adderall, they're being prescribed medications that not only don't help, but may in fact hinder them because of the side effects that Carlos has alluded to. And again, because we don't recognize it and don't have good markers for it, it's gone on like this. We need to shift that.
Yeah, that's right. And that's really what this study is. It's a massive frame shift. Where will people be able to find out the findings that all the researchers who have access to this data? Is it on that same website that we shared? Great.
Yeah.
Well, I want to say to the 650 people who joined and sent in 296 questions in advance, I want to thank you for your continued interest. We know this is hard, a hard space. We know that drug discovery is a critical need. We wanted to make sure that you got introduced, to 2 longstanding friends of the NAMI family who are really trying to get involved in the underlying thing of how do you bin these conditions? How do you identify people that are converting so that you can do better work? So I just want to shout out to the 2 of you and thank you. So let's go on. And last lines, last things you want to say, Carlos and Michael, last comment.
Well, coming from my heart and from my recovery, I want to, special shout out to all the NAMI mommies in particular, fighting for their loved ones, and any, caregiver, father, brother, whoever, I wouldn't be here today if it wasn't for family support, even before, medicines and having a relatively early intervention at my first psychotic episodes. So, you all are the ones, fighting for your loved ones, especially when they're kind of in the throes of the fog and they don't see what's really going on in many cases. So thank you. Keep fighting for your loved ones.
Beautiful. Michael?
I just hope that what you've heard today gives you some hope that there are a lot of people working very, very hard to try and get to a point where, we may be sometime in the future where we are saying, yeah, schizophrenia, boy, that used to be a terrible disease like smallpox, but we don't have to struggle with it anymore. It's an aspirational goal, but it's what gets us up in the morning, many of us, because if we can learn enough to intervene early enough with things that have an effect on delaying or preventing this illness, we will have truly changed the world. And we can't do it without all of you folks helping. So thank you.
Well said, Michael. So thank you both. Let's go to the next slide, please. Coming up, cognitive behavior therapy for families. Dr. Sarah Kapelovich has really, become one of the national leaders on how to use critical examination of one's thoughts and how families can use that to support people. That's on Thursday, May the 8th. Thursday, the 25th, the 5th of June, we have supported employment, which again is an evidence-based practice that is underutilized across the country. Many people want a job, and supported employment seems to be the best way to do it for most people. Let's go to the next slide. Here's a couple of books that NAMI has put together. All the royalties go to NAMI. If you want to learn more about Carlos and his journey, I interviewed Carlos for the first book, and I found him, as usual, illuminating and an incredible source of wisdom. These books are based on lived experience, integrated with research, highly connected to today's topic. Next slide, please. Here's some of our sponsors. Some of these sponsors have been involved in the AMP Schizophrenia project and are asking some of these really hard questions. And I just want to, acknowledge these are big investments companies are trying to make to promote science that is shared, which is different than capital intensive, I'll hold the patent, generate revenue science. Okay, next slide, please. You are not alone. Obviously, this is a educational webinar. It's not to be used for any specific medical advice. And also, if you like what we're doing, considering donating. We have a fantastic team, Jesse, Terry, Hagen, behind the scenes that do all the heavy lifting to make this work. We appreciate your support. Next slide. I want to thank you for joining. My name is Ken. I work for NAMI, which is my dream job. My email address is ken@nami.org. I have an understanding with human resources. No one named Kendra, Kendrick, Mackenzie can work for NAMI. If you have any questions about today's session, email me. I will get back to you. It won't be immediate. Ask the expert at NAMI.org if you have questions for future topics you'd like us to discuss, future experts you'd like to feature, or if you have any other questions. So I want to thank you, Carlos, for all you do, Michael, for all you do, the team behind the scenes, led by Hagen, but, all of us, involved in trying to put together the best resources for people to actually help them. Today was an insight into a gigantic and a very important study that NAMI's been a key part of. So I want to thank everybody for their attention. I want to wish you a great day.